Thank you to the organizers for giving me this opportunity. My topic is prostate cancer genetic testing in its safety net healthcare setting. My name is Kalyani Narra. I'm a hematology oncologist and associate professor at Burnett School of Medicine, Texas Christian University in Fort Worth, Texas. I'm site principal investigator for oncology clinical trials at JPS Health Network. These are my disclosures. So the audience here is international, and safety net hospitals. What are safety net hospitals? This may be difficult for them to understand. So this slide shows the major safety net or majority of safety net hospitals that are part of this coalition called essential hospitals. Safety net hospitals in the U.S. They serve predominantly uninsured and patients on Medicaid. There's high burden of chronic disease, disproportionate representation of low-income communities. 25% of US hospitals are safety net hospitals. These are usually resource-constrained environments. Research at safety net hospitals is limited because of funding, staffing, data system issues. And this is a problem not having safety net hospitals in research because the evidence-based guidelines may not generalize to these populations. And participation of research in these institutions can improve quality outcomes, and we will also learn about the system capacity. So JPS Health Network is in Texas. That's the southern part of the U.S. Yeah, where I pointed out. This is zooming in. This is Fort Worth, and JPS Health Network is also called Tarrant County Hospital District. It's a large hospital, 582-bed hospital located in Fort Worth, and surrounding neighborhoods are included. So 25 community locations are about 1.5 million patient encounters in 2023. And the data I have is from 2023, where you can see that the white population is only 27%, Black population is 27%, Hispanic quite a bit, 35%. Only 19% of patients are on private insurance, and patients speak 80 languages. Coming to the JPS Oncology Infusion Center, we have 5 medical oncologists and 7 advanced practice providers. We have urology care. I'm talking about the prostate cancer. So urology care and genetic counseling are contracted through UT Southwestern. Our chemo infusion suite has 30 chairs. So what is outcomes research? Now, there's a definition by NIH, which says outcomes research is the study of the end results of health services that take patients' experiences, preferences into account. And there are 3 components. One is the healthcare assessment, healthcare systems, and interventions and outcomes. What is the benefit of studying this? And for the individuals, it's improving long-term health and survival and diminished psychosocial distress. And the society benefits from reduced morbidity and mortality in the population. So genetics in prostate cancer, why do we need to study genetics? So the prevalence of germline mutations in prostate cancer is when it is metastatic, it's about 12%. In localized prostate cancer, 4.6%, and in general population, it's only 2.7%. Initially, guidelines recommended that we test all patients with metastatic prostate cancers for germline mutations. Then the diagram on the right that shows the DNA repair pathways that are involved. And several of these mutations, the BRCA mutations, PALB2, ATM, CHEK2, these are all involved in the DNA repair. And PARP inhibitors are therapeutic agents that can several cancers now, like ovarian, prostate cancer, and these these are approved agents for prostate cancer. For example, olaparib is approved for metastatic castrate-resistant prostate cancer with germline or HRR, homologous recombinant abnormalities. Rucaparib is also approved for BRCA mutations in metastatic castrate-resistant prostate cancer. Talazoparib in combination with enzalutamide is approved for HRR abnormalities. And niraparib recently in combination with abiraterone is approved for metastatic hormone-sensitive prostate cancer. We also with the tumor agnostic approval for pembrolizumab for MMR mismatch repair abnormalities, we now have immune checkpoint inhibitors as well. So that it's the prevalence is there, but the therapeutic options are there for patients if they have any of these abnormalities, which makes the reason for us to do the testing. So when do we do testing? Before 2018, the testing by NCCN was recommended for patients with metastatic prostate cancer. But then in 2018, NCCN revised those criteria to include node positive, not distant metastatic, but node positive prostate cancer, as well as very high risk or high risk criteria based on the Gleason score and PSA and others, as well as ancestry and family history. As listed below, listed in the slide. Methodology, how did we do this, conduct this study? So we modeled our study after this publication by Gunn et al. From Boston University Medical Center, where they took 1,800 patients, over 1,800 patients, close to 10 years of recruitment. And the patient population had 44% Black, and it's a safety net hospital as well. 9% were metastatic. 9% of these patients were referred to genetics, which is about 163 patients, and only 20 completed testing. So this was published in JCO Oncology Practice, and we said, okay, RCC Safety Net Hospital with that similar proportion of Black patients, how are we doing? So our oncology, our study was approved by IRB, North Texas IRB. We did, the study included 8 years of data from 2016 to 2023, and we had demographics, clinical variables. We did thorough EHR for staging and multiple ways of finding family history. And the main outcome was the referrals, how many patients, what percentage completed the genetic counseling, and how many or what percentage completed the testing. That was our main outcome. So here, what are our demographics? It's 46% Black patients. We had 40% stage 4. As you can see, stage 1 was 18, stage 2 was 24, stage 3, 18 again, but stage 4, 40%. This is to be noted because the paper from Gunn Boston publication showed 9% stage 4 in a safety net setting. So over this slide also shows over the years the number of prostate cancer that were diagnosed per year, as well as personal history of other cancers other than prostate cancer patient had. We had about 5% with other cancers. Then family history of cancers that we got through the registry, tumor registry, 36% had a family history of prostate cancer or related cancers. So then, okay, what per year, how did we do? To understand this graph, you have to know that we standardize the rate of genetic counseling referrals as referrals based for 100 cases to account for varying number of eligible cases over time. So rate of like the number of prostate cancers in a year is taken as a denominator, and if any patient included in the denominator who had received a referral in the same year was considered the numerator for this assessment. So in 2023, we had 27% of referrals. In 2018, it was 5%. So what did we, how did these patients do? How many patients were referred? So out of 543 patients that we have in the data set, 132 patients, which is 24%, were referred for genetic counseling. 77% of that completed a genetic counseling visit. This is important. I'm going to share that in the next slide, why it is important. We had 11 no-shows, 10 patients canceled, 5 patients declined to schedule, but overall 77% completed the genetic counseling visit. So then out of those patients who completed the visit, we looked at how many actually completed the genetic testing. So here we found 76% of those who were referred or who completed the genetic counseling visit completed the genetic testing. 13 patients had declined testing, and 7 patients had the testing was canceled primarily due to sample issues. Then the 10% had positive test results, and I will show the details in later slide as well. So 70 again, out of 132 patients that were referred for genetic counseling, 78 patients actually completed the genetic testing. Next, we looked at what the characteristic of patients who completed completed the genetic referrals. So as you can see, more referrals were sent for patients who were younger, age of diagnosis, Spanish speakers, Spanish as a primary language, and late stage diagnosis. Both stage 3 and stage 4 patients had higher referral rates. The observed increase in referrals was primarily driven by those with the stage 4 disease. So these are the test results that we, mutations that we found in these patients. BRCA1, CHEK2, BRCA2, MSH2, PALB2, and PMS2. So 3 had mismatch repair abnormalities. So 5 Hispanic patients, 2 white, and 1 Black patients were found to have these mutations. 1 patient had 2 abnormalities. So the takeaway, the main points I want to emphasize from these, first one, the relevance of this study and contrasting it to the other published studies. 40% of our patients were diagnosed at stage 4 as compared to 8% in the US by SEER, as well as the 9% by Gunn et al. This is very significant, and knowing that we have 40% patients who are metastatic helps in organizing our resources mainly to see what we can do in the community to identify patients at early stages and how to channel resources to help patients who are already metastatic and maybe give them more options for clinical trials when we have so many patients in this metastatic setting. And so the main thing is that 24% of these patients, of all our patients, were referred for genetic counseling. Then, since the 2018 NCCN expansion, we noticed that we observed even only after a year after the new guidelines, we observed twofold increase in referrals. And by the last year, which was 2023, there was an approximately 5-fold in referrals. So this increase in referrals allowed for the identification of more individuals with hereditary gene mutations. And And we also has to be noted that even during COVID-19, our referrals increased. Then 77% of our patients who were referred completed genetic testing, counseling appointment, and out of those, 3/4 of those completed genetic testing. This is much higher than other reported literature, where only 10% completed the testing. So what did we do that accounted for this high completion rate? We had a robust genetic counseling service, which is contracted through UT Southwestern, University of Texas Southwestern. Most of like a significant percentage of our patients were uninsured, and we were able to provide financial assistance for the genetic testing. Proactive rescheduling of these patients also happened. Like if the patient missed a genetic testing, our schedulers call them or somehow reach them and able to reschedule. We do that 3 times before giving up. Telemedicine ability during COVID, which we continue to do, has helped as well. And integration of the contracted services into our Epic EHR also we think helped. So the last point I want to emphasize is the diversity in our data set. We had 46% Black, 27% Hispanic, as compared to other studies generally that had 81 to 91% white population. In a gun study I mentioned, which had is 44% Black patients, but other studies that we looked at were predominantly white. And Spanish language preference positively associated with genetic counseling referrals. We think it's because we have an in-person Spanish translator, as well as usually Spanish patients usually come with family members, and maybe they help remind the patients that it's important to have a genetic testing. And so we think our diversity contributed to wide spectrum of detected variants. Before I finish, I want to say that our genetic counselor, who is the second author of our paper, it recently got promoted to be on this NCCN guidelines portion for a genetic familial health high-risk assessment for breast, ovarian, pancreatic, and prostate cancer. And the research is part of CPRIT, which is the Cancer Prevention Research Institute of Texas grant, and proud to share that this research was featured as finalist in medical research awards in the Dallas CEO. The future directions, what do we want to do from this? We think that having an outcomes research or robust outcomes project for prostate cancer, as well as other cancers that we have, we would partner with our JPS Center for Epidemiology and Healthcare Delivery and create an innovation hub to identify how to solve the problem of like having 40% stage 4 patients. Then we will partner with JPS Office of Clinical Research to open interventional clinical trials for patients with advanced prostate cancer. And we would continue to train young generation of clinical researchers and establish collaborations with other safety net health systems to have a wider impact. This has been a teamwork. These are all my co-authors. Priska is the first author. She just graduated medical school and is going to be at Emory University for internal medicine. I would like to thank my tumor registrar, Jolanda Bullock, Office of Clinical Research Biostatistician, Sam Newman, IT Business Intelligence, who's not at JPS anymore, but Kyle has been a huge help, and our UT Southwestern Cancer Genetics Program, both Jackie and Jana, as well as my mentor, Dr. David Gerber. Okay, thank you.